So we will have 2 ASL interpreters that will alternate throughout the session. If you want to see the interpretation, you will pin these boxes to your main screen. These are ASL interpreter Elisa and ASL interpreter Kristen. In order to pin the interpreters, you will select gallery view from the upper right corner of your screen. Click on the ASL interpreter screen, select the More button or 3 dots. You will select Pin Video and repeat this process for the second ASL interpreter. And thank you to Elisa and Kristen for their assistance with us today. Next slide. We begin all of our presentations by reviewing the Behavioral Health Administration's values, which we are very proud of. And those are truth, equity, collaboration, community-informed practice, and generational impact. And these 5 values are things that we take into consideration in every stage of this rule promulgation process, from drafting to stakeholdering, in order to co-create a people-first behavioral health system in Colorado. Next slide. Some housekeeping for today. I will present most of the slide and then we will go back to BHA staff introductions. We do have 2 hours booked today from 11 a.m. to 1 p.m. This video will be recorded and posted on the BHA's YouTube channel. The BHA YouTube channel link may be found on the BHA website, and we will also be dropping it in the chat throughout this presentation. BHA staff will have access to the chat and transcripts to ensure comments are captured, and we encourage you to share whatever you are comfortable with in this venue. In this town hall, you may use the chat function to ask questions or provide comments, or you can raise your virtual hand and let us know what those questions and comments are yourself. We will be pausing throughout the presentation to take questions. We also have ways to reach out to us outside of this meeting. We have the email, which I believe was just dropped in the chat, our email inbox. You can also use our Google form to submit feedback. Just a reminder that feedback, the deadline to get feedback into this particular rulemaking packet is this Friday, June 23rd at midnight. So yeah, appreciate you joining us for our final town hall in chapter 15. And please remember to get any questions or comments in by the end of this week. We will go ahead and do our BHA staff introductions. My name is Victoria Lasky. My pronouns are she, her, and I am the Safety Net Associate Director at the Behavioral Health Administration in our Quality and Standards Division. And we will go ahead and introduce our other presenters and special guests for today. And I will start by handing that over to Tom.
Thanks very much, Victoria. Tom Miller, Division Director of the Quality and Standards Division. He, him, his pronouns. Would start with thanking all of you and your participation, not only in this particular forum, but probably many other forums. And again, not only in what I call round 2 of our rule promulgation process, but round 1 as well. You have helped us make these rules better, and by doing so, improving the behavioral health system itself. The other set of thanks I want to give is to Victoria, the Safety Net team, and our newest members of the BHA, Jessica and Courtney, who will introduce themselves here in a minute. If you've been in any of these stakeholder meetings, you've heard me talk less and less, which is a good thing, but that is primarily because Victoria and her team have developed a tremendous expertise in these rules, and I couldn't be prouder as a division director of all the folks in the Quality and Standards Division, but in particular the Safety Net team. So as we draw to a close with our rule promulgation process, wanted to extend my personal thanks to everyone in the division and in particular on the Safety Net team. Thank you very much. With that, I will pass it over to Eric. Whoops, did I catch it? Sorry, Erica.
I just am not speaking today, but I can introduce myself in case any questions come my way. My name is Erica Gannett. I use she, her pronouns, and I'm a safety net licensing manager here at the BHA. I primarily focused on chapters 3 and 4, the safety net provider approval and care management chapters. And I will pass it over to Olivia.
Hi, everyone. Thanks for being here today. Olivia Zern, she, her pronouns. I am also Safety Net Licensing Manager and one of the drafters on this chapter 15. And I will pass it off to Mel.
Thank you, Olivia. Hi, everybody. So glad you're here today. I am Mel Tyler. I am also a Safety Net Licensing Manager, she, her pronouns. And I also worked on this chapter 15, and I will pass it over to Jessica.
Hi, everybody. Jessica Bell, Associate Director for the 2765 unit. Pronouns are she, her. I'm very excited to join you all in this. I'm going to pass it over to Courtney.
Hi, I'm Courtney Jurish. I am the 2765 Program Manager, she, her pronouns, and appreciate being part of this town hall today.
Great, thank you, everyone. We can go on to the next slide. So in today's town hall, this will be a more presentation or content heavy event. If you've been to other of our stakeholder events, some of those are more of a listening session style. We had our final in-person listening session in Pueblo yesterday. So I see some folks that were there yesterday here today. Good to see you again. And today will be a little more presentation heavy, where we will be reviewing the content of chapter 15, our 2765 designation of facilities for the care and treatment of individuals with mental health disorders. So those involuntary mental health services. Just a note of clarification. If you have been following this process, this was formerly called chapter 17. We had consolidated some chapters due to stakeholder feedback and incorporated, for example, withdrawal management throughout the spectrum. And so we are now having a couple of different numbers. So just want to make sure that that's clear that this chapter 15 was formerly chapter 17. We also have the website link available for upcoming events. This is our final public stakeholder event for this particular part of the rule drafting process, but we will be sure to use that calendar for other upcoming events as those are planned. And we also are happy to announce a new way to stay informed. We have a quality and standards newsletter that we will send out periodically. This is separate from the BHA's overall newsletter. This one is really specific to quality and standards topics, such as the rule promulgation process and things like ladders system updates. So please be sure to sign up for that. We had our first newsletter go out last week, I think, and we are preparing our next distribution. So please be sure to sign up if that is something that is of interest to you. All right, and with that, we will get started with our presentation and overview of some of the legislation that led to this chapter, and I will be handing it on over to Jessica.
Thank you, Victoria. So we are going to go back through really quickly the statute that made all of these changes before we jump into the chapter, because it will help inform our next part of the conversation. So some things to keep in mind: House Bill 22-1256 is where all of these really big changes come from. Prior to this statute change, the statute around involuntary mental health holds had not been updated since the 1970s. As you can imagine, it needed quite a bit of an update. So some of these significant changes: there's an expansion to patient rights, including an entire section of outpatient certification rights, required discharge planning, and an expansion of who can place or remove involuntary mental health holds. And so we will continue to discuss those as we go through chapter 15, the 2765 designation rules, and a little bit more in depth of this bill. Next, please. So some of the things that are already in effect has changed this intervening professional definition. We've removed peace officers and have added advanced practice registered nurse and physician assistants. So an intervening professional With the removal of that peace officer, they will have other responsibilities related to transportation and transportation holds. Any RNs that are going to be participating in these mental health holds will need to complete a BHA identified training so that they have the correct training and information to initiate these holds. There's more information around voluntary hospitalization of minors. Minors over the age of 15 can consent to voluntary hospitalization. Any individual who is now on a certification has a right to an attorney. There is a new transportation hold, so the M0.5 will be updated and is updated. We're in the last couple of days before it gets posted. There are new requirements for terminations of certifications, including that notification to the BHA. If you're not aware, there is a link on our website, and we will talk about that a little more in just a bit. Long-term certification petitions now can include inpatient or outpatient recommendations. As we mentioned, the new discharge requirements are in place. BHA will promulgate rules and develop and distribute forms. As you've seen in any of our town halls that we've been doing, this is going to be this new chapter. This is going to be updated M forms, and there will be a new standardized evaluation form. We will be training providers, facilities, counties, judges, intervening professionals, certified peace officers, and the lay people, anybody that has a family member potentially that is on a certification around these new updates and how the process works. Next, please. Originally, some of these were going to go into effect July 1st of this year. Now they are pushed back to January 1st of 2024. One of the big ones has been this new emergency procedure statutory language is now no longer that 72-hour hold. It is now emergency mental health hold. Discharge instructions with all the required components will be listed in this chapter, and they will be provided to all people on an emergency mental health hold prior to their release. As mentioned previously, the standardized evaluation form will be used. That is in production. BHA will begin assisting emergency medical service facilities in finding solutions for difficult to place folks. So this is going to look more like care coordination and how to help individuals navigate our system. There will be an update that will allow subsequent involuntary mental health hold in both designated and non-designated emergency medical facilities when appropriate placement cannot be found. Again, that's going to be part of care coordination, and we will discuss that a little bit more in a second. And there are new patient rights for short-term and long-term certifications, and also for transportation holds. Next, please. And so the last piece of our timeline is effective July 1st of 2024. This is going to be that care coordination for certified individuals. Going back to that previous slide, it's talking about anyone who is hard to place. They're stuck in an emergency department and need assistance in finding placement. The BHA will help with that coordination piece. The outpatient certification for both short-term and long-term. There's some new pieces in effect that will help limit liability for providers, talking about how the outpatient facility will proactively reach out to clients to engage them in treatment. And if that person refuses that treatment, the court may order a transport to a designated facility to receive treatment. And the individual in that case does not need to be imminently in danger to self or others. The limited liability for designated facilities is the example of terminating a certification despite that person meeting criteria. And we can discuss that a little bit further in the chapter. A new certification provision, anyone may contest the treatment regime at any court proceedings. This could be that individual, this could be a family member. And there are new provisions for termination of short-term and long-term certifications. Next, please. So as I mentioned, House Bill 22-1256 is where these new updates came into play. House Bill 23-1236 gave us our new implementation timeline. So some of those timelines that changed, the behavioral health entity and safety net rules have an extension from 7/1 of this year until January 1st of next year. Same thing with the behavioral health administrative service organizations and the 2765 extensions. Next, please. So we did discuss quite briefly the extended implementation of the timeline. So services that were to be provided to individuals on an involuntary hold beginning July 1st, excuse me, I'm so tongue-tied today, will now be January 1st of 2024. The new data reporting requirements for emergency departments has also been pushed back to July 1st of 2024. Next, please. So again, to kind of recap some of those key provisions, those updates to patient rights at every part of the involuntary procedure, the updates to who can place the transportation holds, major updates to the involuntary mental health hold process, and it also creates the first ever statutory section specific to outpatient certifications. New data reporting and those requirements will be listed in this chapter. It's also listed in that statute. Again, those new responsibilities for the BHA, and one of the exciting pieces is we will have the ability to bring on board some more staff to support these 2765 programs in the designated facilities. And as mentioned, there was 3 different implementation timelines. So where are we at right now? So the new updated statutory sections are in place. A lot of these just have new numbers or have been ordered. For example, 2765-103 previously was the treatment of minors. That is now found in 2765-104. Again, as I mentioned, the new intervening professionals who can place or a hold or terminate a hold, that definition has been expanded. Transportation hold. So this one is brand new as far as mental health clinicians can no longer place the transportation hold. There are new rights that go along with this transportation hold, and there is a new M form specific to transportation rights. The transportation rights do need to be provided to the individual prior to their transport. Right now, those that can place the transportation holds will be peace officers and emergency medical services. Part of this is that screening, once they have been taken into, once they've been involuntarily detained, the screening must occur immediately upon arrival to a designated outpatient facility. If for some reason that professional person is unavailable, that screening must occur within 8 hours. This piece of this provision in the statute does not apply to emergency departments. So all people who are certified, both short-term and long-term, right now have the right to an attorney. Respondents can waive counsel, but they must do so in front of a judge. All individuals terminated from certification, regardless of reason, regardless of short-term or long-term, must be reported to BHA. On our website, if you go to the resources tab and go down to involuntary mental health treatment, the bottom of the page, there's a certification termination reporting link, and that's where you will put your reports for each individual that has been terminated. There will be multiples for multiple individuals who have gone on multiple certifications throughout the year. We are aware of this, but we do need to report on every single termination. As mentioned previously, one of the big changes was that 72-hour hold is now changed to emergency mental health holds. This outlines that law enforcement also has the discretion to ignore a warrant. This is really important because if it's in the best interest of the individual to be seen for mental health reasons first, then they can ignore the warrant and take the individual to a designated facility or an emergency department. There are some other requirements by law that law enforcement will have to follow. This does separate a peace officer from the definition of intervening professional, but creates 2 separate pathways for placing an M1 in the community. So one of those pathways is specific to law enforcement, and the other one is specific to the intervening professionals. One of the things that we received some feedback on was changes in that statute language around admitted, specifically for people admitted into the emergency department. That has now been changed to detained or presented. So that subsection is specific to emergency departments. There's also some information in there around the emergency mental health hold that ends after 72 hours is placed. And as I mentioned previously, there will be an option for subsequent hold beginning January 1st of 24. So this is very specific to if you can't find placement for this individual. They also continue to meet criteria for that emergency mental health hold. And the emergency department will contact BHA and we will coordinate placement efforts. The specific processes for that is still in production and still in the works, and we will continue to update you as we have more information. Next, please. So something to be aware of, any person, voluntary or involuntary, that's been waiting for placement in a facility for longer than 72 hours, we must be notified. And this will also help with that finding appropriate placement option. So this bill provided BHA with funding to hire additional FTE to support our facilities 24/7, 365. Unfortunately, it did not give us additional beds, but it does create an additional support system for our providers. If the person is in an emergency department and that appropriate placement cannot be located, as I mentioned, they can place them on a subsequent 72-hour hold. If the person has recently transferred from an emergency department to a designated facility, the facility can demonstrate that they do not have time to evaluate the person for certification before the hold expires. They can also place a subsequent mental health hold. But the BHA and that person's layperson will need to be notified. Sorry, can you hear me now? I'm getting some feedback that it's hard to hear.
Jess, thank you for responding to that. I don't know, just maybe move a little closer.
Yeah, it's my microphone and it's so hard to really get a good grasp on where it's at. Okay, I moved the computer, so hopefully you can hear me better now.
Yeah, whatever you did made a difference, at least for me. Thank you.
Okay, perfect. Something to keep in mind, the BHA will maintain data on all of these subsequent holds. This is not a requirement for individuals. Next, please. So the emergency mental health evaluation, this is a brand new form that has come out of this statute update. These evaluations may be completed by your professional person, as we have listed here. They do need to have 2 years of experience in behavioral health safety and risk assessment, and must also work in a healthcare setting. This also clarifies that this person in charge of the evaluation, once completing that evaluation, may drop the hold. So this standard evaluation form is going to be created by the BHA, myself and my team, and we will be rolling that out for stakeholder feedback. I know this says by the end of 2023, we are hoping to have that feedback, or that form out to everybody for feedback with considerable time prior to this January 1st implementation date. Something to note, this is separate from the crisis assessment. So this mental health, emergency mental health evaluation is something that would take place once an individual is on an M1 hold. Next, please. So some of the reforms coming of July 1st next year, these certification changes, this outpatient certification with provider immunity. BHA is going to also create a one-step grievance process. Again, this is the exact process is to be determined, and we will continue to update providers as we have more information to share. This allows the respondent or their identified layperson or guardian to contest the treatment, including any court-ordered meds at any court hearing related to this certification. This outpatient certification also outlines judicial process if the person is placed in a more restrictive setting, what happens to the individual, what happens with the certification, and it adds specific rights to the person certified on an outpatient basis. The court can order, can order a secure transport provider and not just a peace officer to pick someone up from outpatient certification, should they be not in compliance with the requirements of their certification. Again, we will provide care coordination for all individuals on that certification. So here's a quick overview of that timeline. Again, those updates to the M forms, including the new patient rates. I'm sorry, I misread this when I was editing it. It says by June 1st, it's actually by July 1st. So we're just a week out. Updates to the rules that will go into effect January 1st. Process for notification of to the BHA that is already currently in effect. Creation of stakeholder process and that standardized evaluation form. Again, that will go into effect January 1st. Supporting placement for individuals. That one has also been pushed back. The one-step grievance process we discussed, process for the care coordination, and then training and technical assistance. So I'm seeing a lot of comments about this crisis assessment and the evaluation. So something to keep in mind, your crisis assessment, and again, this evaluation is not created yet, and this is where that stakeholder feedback will be so important. The crisis assessment is something that would happen initially to determine whether a hold is needed for an individual. That standard form that was created by Megan Lee and her team, at the bottom of that standardized form, you can see that it gives you several options, including placing a hold. So this emergency evaluation is going to be done after that hold. And again, because there's a lot of overlap between this crisis assessment and your evaluation, I'm going to rely on stakeholders quite a bit to help so that we're not duplicating efforts and duplicating work. So the assessment is going to be on the website. I know it is with our communications team. Unfortunately, I do not have an update as to when that will be available. I'm sorry, I don't understand your question, Erin. And we can discuss the specific evaluation form in another town hall. I know this one is very information heavy around chapter 15. And so I don't want to sidetrack us. Next, please. So part of this House Bill 22-1256, BHA was provided funding to hire additional FTE to provide that support to our emergency medical services facilities to help with that placement search when there is no appropriate bed to be found. As I mentioned previously, this bill did not include additional beds, but will provide that additional support to have additional people searching for placement that is appropriate for the individual in question. And so as we continue to update that, this will be on our involuntary treatment page of the BHA website. Next, please. The creation of the one-step grievance process. Again, this will be an entirely brand new team of folks only dedicated to complaints and grievances. They will be hired in the coming months, and they will handle all of those pieces separate from our quality and standards licensing program managers. There will be a special web page for these and their loved ones to make a complaint or grievance as straightforward as possible. So there's not several different options for them. There will be a one place that they can file a complaint or a grievance against any treatment and care they receive. And we will continue to update this process on our BHA website. Why the need for the emergency mental health evaluation? Thank you for your question. So the emergency health evaluation is specific around whether or not this individual will go to certification. So this would be a form that would be submitted to the courts when asking for certification. Karen, I will let Tom answer your question around if providers can file agreements through that process as well. Some more information on this care coordination piece. We will have the entire team dedicated to care coordination, and it's currently being developed. There might be an opportunity for some contracting with our bosses or with the RAIs to help in this process as well. Any individual on a certification who does require some additional care or some support will have access to these services. And we will, again, continue to update the processes and anything involved on our involuntary treatment page. Training. I apologize if you hear noise in the background. Thank you for answering that, Tom, in the chat. Lastly, some training. House Bill 22-1256 did allow us to hire some additional FTEs and develop and implement some community trainings specific to these processes. And we're going to have a variety of trainings. We're going to have some that are targeted directly towards our peace officers, some towards our EMT professionals, providers, both designated and non-designated facilities, our county providers, judges, magistrates, any intervening professional and professional persons who would oversee certifications, and also some lay people, family members of our individuals, so they can know what to expect and know how to navigate the court processes around their loved one's certification. We will do some online training that will always be available so that we can put them either on the website or through the BHA YouTube channel. Others will occur in person, and we will also provide some virtually. Next, please. And I'm going to pass this off to Olivia.
All right, thank you, Jess. And real quick, I probably will pass it back to Victoria just to make sure we captured all of the questions in the chat that we have time for before I go more into chapter 15.
Yes, we've got an active chat today, so I'm trying to keep up as able, and I know Jessica was addressing some of these as we went, and I know that we have limited time today. So I saw one earlier from Angela about training for RNs available yet. My understanding is not yet. Do we have an idea of the timeline for that at this point, or is that an update to come?
That will be an update to come.
Great, thank you. I saw another question about the data reporting requirements, and Olivia responded that we will be going over those here shortly, so hang tight for that one. There was a question from Tammy: will co-responders working with law enforcement officers be able to execute the M.5 holds?
I'm sorry, can you repeat that?
Yeah, absolutely. Will co-responders who are working with the law enforcement officers be able to execute the M.0.5 holds?
No, they cannot.
Thank you for that one. Oh, and I see Mary has a raised hand. Would you like to come off mute?
Yeah, so I think I can tell there's, I think maybe more questions than answers on some of this regarding the assessment versus the crisis evaluation and who can do what. So I think for a lot of us on this call, we work at non-designated facilities, hospital settings, and we either receive patients already on a hold or they come in the door and need assessment for a hold. And we're still unclear who's able to do that evaluation and on what form, because there was a comment about the evaluation, emergency mental health evaluation was only for a designated facility, determining if a certification was needed. Anyway, I think we all have a lot of questions about that.
Yeah, sorry about that. So the evaluation is for designated and non-designated. It's specific to what would you provide your court officers if you needed to have that documentation stating an individual has refused voluntary services and they need to be certified for either inpatient or outpatient certification. And so that crisis assessment, again, the evaluation is not completed. It's not created yet. So the crisis assessment is something that I don't want to duplicate in our evaluation. And I will rely on stakeholders to essentially help build this evaluation so that we're not duplicating work, we're not duplicating efforts. Your evaluation is going to be completed by your intervening professional, as we have defined both in statute and in rule.
So RN still could not do a crisis assessment, correct?
So the crisis assessment is different from the evaluation.
I think
And I would
the confusion might be on that you begin to talk about certification, but the way it was presented, or as I understood it, that it's the crisis assessment, you decide that there's a hold, and then once they're on the hold, you're then doing this emergency mental health eval. But it sounds like that's not really related to what we know as the M1, that's only for the outpatient cert. Is that what you're saying?
So it's not specific to outpatient, but it is specific to certification. So if you think of the different paperwork in a continuum, you essentially have your crisis assessment first, and then you would have your M1 application hold. And then from there, you would do an evaluation. And again, I don't want to duplicate all the work that providers are doing. I know a lot of work goes into the crisis assessment. And so the evaluation will hopefully not be any duplication of the work you've already done leading up until that point. Does that help?
A little bit. I mean, and for one of the things for the crisis evaluation, can that only be a licensed professional or the people that can initiate the M1 holds, or can that be unlicensed staff as well?
Are we talking about the evaluation?
The crisis assessment, the beginning part of the crisis assessment.
So I'm going to defer to another individual on who can do that because that crisis assessment is not created by my team and I'm not as familiar with it. Olivia, is that something that you'd be able to answer?
I think that might be a Tom question.
Sorry that we're playing hot potato. We were chatting behind the scenes, and I am going to work with the division director for statewide programs, one on where we are in the process of developing the form, because it was the crisis folks that were developing that form and have thus far maintained the expertise around that. So I will follow up on both things, where it is and who can complete it.
And then one, yeah, I think we're all still quite confused, more confused. One further question though that we've asked on a couple of occasions, needing the 2 years of experience in a healthcare setting. If you can't do those evaluations until you've had 2 years, how do you get the 2 years of doing that?
So Olivia was kind enough to supply the statute in question, which has that requirement. And so this is from House Bill 1256 in Section K. It requires that each evaluation be completed using the standardized form. We approve that form and may be completed by a professional person, a licensed advanced practice registered nurse with training in psychiatric nursing, a licensed physician assistant, a licensed clinical social worker, a licensed professional counselor, licensed marriage and family therapist who has 2 years of experience in behavioral health, safety, and risk assessment working in a healthcare setting. So I know that's the question that you're asking. I wanted to make sure that we all had the information and understood that that requirement comes from the statute. The related provision that immediately follows in the law is if the individual conducting an evaluation pursuant to Part 15.14 of these rules is not a professional person, and the evaluating individual recommends the detained individual be certified for short-term treatment pursuant to the section, the evaluating individual shall notify the facility of the recommendation. So I think that that's a somewhat confusingly worded section, and the interpretation that I'm going to check on is if we can use that to apply to the requirements in Section K proceeding to essentially have an exception to the 2-year experience requirement. I don't know whether that's possible. We do recognize the position that you and your staff are in as a result of that statutory requirement. So the short answer is we need a legal interpretation of that particular section.
Okay.
Thank you for asking.
Thank you.
Thank you. And I see another hand up, Erin, if we want to take Erin's question or
Oh,
comment.
no, I'm sorry. Mine was previously.
Oh, excellent. Sounds good. I see that there were, again, a lot of activity in the chat. I think what we might do is continue on with the presentation. We will try to address in writing the questions in the chat as we can. And then if there is additional time at the end, we can continue answering questions live. Otherwise, we can take those back. So we will continue on with Olivia.
Thank you, Victoria. All right, so now I'm going to go more in depth of chapter 15. Our main sources for this were 2 CCR 502-1, House Bill 22-1256, House Bill 23-1236, and then your stakeholder feedback. Next slide. As always, we do like to start our chapters off with our person-centered summary. For chapter 15, we have, if you are in danger of hurting yourself or others, you may be placed on an emergency mental health hold. 2765 designated facilities refer to facilities that are capable of providing services to you should this happen. Services may be provided on an inpatient or outpatient level of care, depending on your ability to take care of yourself or your risk of harm to self or others. Emergency mental health holds are placed on people that are a danger to themselves, for example, participating in self-harm, having thoughts of suicide, or even having had a recent suicide attempt, and are unable to remain safe. They may also be placed on people that are a danger to others, so threatening to hurt someone else, or someone that may be gravely disabled, which means that your mental health has gotten so severe that you are incapable of basic self-care, such as not showering, brushing your teeth, missing work, staying in bed all day, not eating or drinking, etc. If you do find yourself placed on an emergency mental health hold, this means you must be involuntarily taken to treatment in order to keep you or others safe. There are patient rights in place that the emergency medical services facility and or the inpatient or outpatient facility must adhere to. During treatment, you will be stabilized and gain tools and resources to better your mental health. And once you're able to keep yourself safe again, your hold will be discontinued. All right, so our chapters always start off with our definitions. So for chapter 15, all of our definitions have been updated to reflect additional statutory definitions from that House Bill 22-1256. We also did receive a lot of feedback from stakeholders to not exclude appropriate providers of assessments and services. So we did fix those definitions. And then just wanted to note that not all definitions will be in chapter 15. If any definition was used across chapters, that will be found in chapter 1. For example, our definition of authorized practitioner will live in chapter 1. This means a person A, authorized by law to prescribe treatment, medication or medical devices, B, who holds a current unrestricted license to practice, and C, is acting within the scope of such authority. This person may also be registered with the DEA to prescribe controlled substances. This includes, but is not limited to, a physician, psychiatrist, medical doctor or doctor of osteopathy, physician assistant, or a licensed physician assistant, and an advanced practice registered nurse. Next slide. So these definitions are specifically in chapter 15. So I know Jess touched on this earlier, but intervening professional plays a big role in chapter 15. This means an individual who is statutorily permitted to enact an emergency mental health hold. Intervening professionals must be one of the following: a professional person, which I will read that definition next, a physician assistant, a advanced practice registered nurse, a registered professional nurse who has specific mental health training as identified by the BHA, a licensed clinical social worker, a licensed marriage and family therapist, a licensed professional counselor, and a licensed addiction counselor. There was some confusion around whether certified peace officers will still be able to initiate a mental health hold just because they were removed from this definition. They are still able to place mental health holds. All right, professional person. This means a person licensed to practice medicine in this state. This does include advanced practice registered nurses. In previous variations of this chapter 15, that was not included, so just something to note. This also includes a psychologist licensed to practice in this state, or a person licensed and in good standing to practice medicine in another state, or a psychologist licensed to practice and in good standing in another state who is providing medical or clinical services at a treatment facility in the state that is operated by the Armed Forces of the United States, the United States Public Health Service, or the United States Department of Veterans Affairs. Physician, this means an individual licensed to practice medicine in the state, not including advanced practice registered nurses. And then lastly, we have our layperson definition, which means an individual identified by another individual who's detained on an involuntary emergency mental health hold, certified for certified for short or long-term care and treatment, who's authorized to participate in activities related to the individual's involuntary emergency mental health hold, short-term treatment or long-term treatment, including court appearances, discharge planning, and grievances. The individual may rescind the layperson's authorization at any time. Okay, moving into the general 2765 designation requirements. All agencies that are providing involuntary treatment services pursuant to Article 65 of Title 12 shall meet the standards in Chapter 15. Any facility that is licensed by a state agency, including CDPHE or the Division of Child Welfare within the Colorado Department of Human Services, providing involuntary mental health services, whether on an inpatient or outpatient level, shall also seek a 2765 designation. And we did just want to note that if a facility is also a behavioral health entity, they must comply with all of Chapter 2. And if the facility is a safety net provider, they have to comply with all of Chapter 3. A designated facility must also comply with regulations specific to the involuntary services it provides. This includes the involuntary emergency services designation, the involuntary short-term and long-term inpatient care and treatment, and or the involuntary outpatient care and treatment. And we will go into more detail of all three of those later in the presentation. So there was some confusion about addresses and what needs to be designated. So facilities providing 24-hour inpatient or acute crisis care must apply for a separate designation based on the unique physical address of each site. If two or more buildings share a physical address, each building must be designated separately for 2765 services. So if a medical hospital applies for 2765 designation, each specific unit or floor has to be designated and must be specified on the application. Next slide. Thank you. I am going to now pass it off to Courtney, who will go into more depth of those new data requirements.
Thanks, Olivia. So these slides were supposed to be presented by our data person, Jasmine, but she was unavailable. So I need you just to bear with me. I have her notes, so hopefully I can still get the information across that you need. There may be some questions we have to take back to her and get back to you on. So feel free to put them in the chat, and that will help us keep track of any questions, and hopefully we can answer some here. So the data requirements don't actually start until July 1st of 2024. So I think that's maybe the good news to start with, is that we have about a year to implement these changes. So the data requirements, the 2765 facilities are going to start submitting disaggregated data. Previously, we had requested aggregated data. This is a big difference to get the disaggregated data. The data needed for emergency mental health holds will be on the individual receiving care, who initiated the hold, why the hold was placed, disposition information, placement challenges of any, reasons for subsequent hold, which will be that additional 72-hour hold if that will go into place soon if that's needed, any involuntary transport hold information. Then disaggregated data will be for long and short-term certs, voluntary patients, involuntary medications and treatments, ECT, emergency medical facilities, whether they're designated or not. Next slide. So House Bill 1256 outlines many data reporting changes for 2765. The most notable changes are in the client level data, the placement data, the certification data, and annual reporting. So client level data will now be collected from each of the 2765 service providers, regardless of their designation status. This includes data such as client ID, first and last names, demographic data, types of services accessed, for each individual who access care. And I will get to tools and training in just like 3 slides, if you just want to hold tight for a sec. So this means that if an individual access multiple services from one provider, there'll be multiple records for that individual in the data set. And this data has been previously collected, but now will be submitted to the BHA in a disaggregated format. Replacement data, this is a new category of data collection, designated 2765. Service providers are required to submit data related to client placement and any issues related to placing individuals at a facility that matches the individual's level of need. This is data such as placement wait time, did the facility ask for assistance from the BHA and any challenges to placement? And placement data will require the providers submit data related to subsequent holds and the reason for subsequent holds. Under certification data, we will collect additional data related to short and long-term certifications. This includes data related to the termination of certifications, such as the reason for terminating the certification and housing and employment data. Providers will be required to track the services the individual receives during the duration of the cert. And in the annual report, the BHA will develop an annual report to provide the state overview of 2765 programs every year. Next slide. So there's a lot of questions about why these data reporting requirements changed. And basically these changes align with and uplift the BHA values. The BHA is committed to understanding the communities we serve, as well as those communities we are currently underserving or missing entirely. We are seeking to understand how services are provided to Colorado communities and how to increase access to these services and how to sustain services for future generations. All the data collected will be given back to the community by way of the statewide annual report that will give stakeholders insight into how 2765 services are provided and what benefits individuals who access the services have received. I think that's all I have on that one. We can go to the next slide. So on how to report the data, the BHA, as they have in years past, will provide facilities with a template in which they are required to enter the data and submit to the BHA by July 1st every year. The designated facility template will differ slightly from the non-designated facility template. And this is due to designated facilities' ability to provide an increased range of services as compared to non-designated facilities. The BHA is currently working on the new reporting template. It will look similar to the client level reporting template that was effective prior to 2018. In the meantime, please ensure 2765 staff are well-versed in the data reporting changes outlined in the statute. Next slide. So to answer some of the technical assistance and training questions, as these changes begin to go into effect, our team members and the data and evaluation team will be providing technical assistance as needed. The BHA will do an instructional video of how to use a data reporting template, and the BHA will also establish 2765 data office hours to ensure consistent access to technical assistance and support with data reporting needs. So with that, if you have any questions, I see that there was a lot in the chat. It looks like there was responses, but Victoria or whoever, let me know if there's some that we missed.
Great. Thanks for that, Courtney. Yes, we are working on drafting some answers in the chat and have done so already. And I do have a couple of questions that I'm going to pose to Tom. So Elizabeth asks, so RCCFs and QRTPs would need to be designated. Could you explain under what circumstances that would be true, Tom?
So if an RCCF, which is really an umbrella for a PRTF, or a QRTP, if we're really getting into our alphabet soup here, the current state is that they're designated to take a person that's on a shorter long-term certification. That essentially is not changing. If such an RCCF wants to continue that, they would need to apply for the 2765 designation and go through that renewal process. Though it wasn't asked and probably somewhat outside of the scope of this particular chapter, I would just add in, because there's been a lot of additional work when it comes to residential childcare facilities, and that is that through the amendment that we did at the very end of the legislative session, we removed the prohibition for an RCCF to be licensed as a BHE. So if an RCCF does want to provide CSU services, or probably more likely wants to provide SUD services, then it can optionally apply to be a licensed BHE. So hopefully that added additional nuance and not additional confusion.
Great, thank you for that, Tom. An additional question or comment from Megan about facilities needing guidance at least a year in advance to make sure they are tracking data correctly and going into the actual reporting deadline. Did you have any comments on that one?
Hi, apologies. Oh, sorry.
No, Megan, go ahead.
Yes, and I know, just wanted to flag, we obviously had a couple of technical experts dig in on the comments as well, kind of about the EHR build, so would defer to them on the timeline, but we are hearing from our members at least a year in advance. Otherwise, they would kind of miss the reporting window in July, unfortunately, and just appreciate all your assistance.
Thank you for that. I recognize when I told Victoria I would try to help that I probably misunderstood the question for the bulk of the reporting requirements. I think we're going to have to circle back with our data division and talk with them about that. Part of how I misinterpreted the question was about enforcement of some of the data reporting requirements, or perhaps enforcement in general. And one of the things that I've been working on behind the scenes that was really a holdover in some ways from when we were talking about making these rules effective October 1st. If any of you remember that particular nuance, seems like a long time ago now. But at the time, we were negotiating with providers and provider trade organizations to have a delay of enforcement of those rules. And we are prepared to also have a delay of enforcement, except in cases where there's a health, safety, welfare issue for a recipient of services. So looking at a very likely delay of enforcement until April 1st, assuming that the rules do get passed and go into effect January 1st of 2024. So while I don't think that's a specific answer to your questions, Megan, I did want to take the opportunity to share that information. I think back to you, Victoria.
Great, thank you for that. For these data questions, we noted that unfortunately our data expert was unable to join us today. So for those that we do have a response to, we will respond in the chat. And if not, those are ones that we will gather and take back to Jasmine. So appreciate you bringing those to our attention. All right. Anything else anyone wanted to address before we continue on?
You see that there was a request from Bridget for additional terms, definition of terms. We'll take a look at that. Thank you, Bridget. Also, Mona Allen asked for a clarification about when data reporting requirements begin, July 1st, 2023, or is it 2024? So we will take a look at that. Unless anybody on the call has a very specific answer right now. I don't see anybody coming off of mute. We will clarify that.
All right, with that, we will continue on.
Great, thank you so much, Victoria. Hello, everybody. It is my turn to talk to y'all. And I'm going to continue going over changes to Chapter 15. So some general standards that you may see have changed. One of those is the leadership personnel requirements, or just personnel requirements in general. There's a minimum leadership staff requirement to both short and long-term certification facilities that they must have both a facility director and a clinical director. Also, these facilities need to have qualified individuals to administer those medications at all times, or QMAP registered individuals. So that's now included in that medication administration section of the chapter. There's also more detailed information around the individual records section, particularly that all professional persons and or facilities providing evaluation, care, and or treatment shall keep their records detailing all care and treatment received by the individual at their facility. And the records must be made available upon the individual's written authorization to the individual's attorney or the individual's personal physician. Next slide, please. Woo, this is a big slide, a lot of words there. So we have a lot of new information from that 22-1256 bill, particularly around discharge summary requirements. So this is from 2765-106. The discharge summary and care coordination instructions must now contain the following: a summary of why the individual was detained or evaluated for an emergency mental health hold, that detailed information as to why the evaluating professional determined the individual no longer meets the criteria for an emergency mental health hold or certification, and the reason why they were discharged. Whether the individual may receive services on a voluntary basis, if the individual's medications were changed or the individual received a new prescription while receiving treatment at that facility, a clinically appropriate supply of medications need to be documented and provided to the individual, as well as that determination by the judgment of a licensed mental health care provider for the individual until the individual can assess another provider or follow-up appointment. The copy of the safety plan for the individual, it needs to be documented that it was provided to that individual and then also included in that discharge summary if applicable. And the individual's layperson, if they were provided a copy, again, if applicable, where indicated by the individual's mental health disorder or mental or emotional state. There needs to be notification to the individual's primary care provider, if applicable and known who that primary care provider is, a referral to appropriate services once they are discharged. So if it is identified while that individual is in care that upon discharge, that individual may be without food or have a lack of housing or economic security, we want to make sure that that individual is receiving appropriate referrals and linkages, and those must be documented in that individual's record. Next slide, please. Further in that discharge summary, we want to make sure that that phone number to call or text the Colorado Crisis Services hotline was provided to that individual and documented in their record. We also want information on how to establish a psychiatric advance directive if that individual is not aware of how to do that, or if they have an advance directive, a psychiatric advance directive, that there's a copy in the file. We want to make sure that there is a list of any screening, diagnostic testing, therapeutic treatments, and laboratory work that was provided or collected while they were in treatment, so that it can be provided if requested by the individual. And then lastly, how to contact the discharging facility if any further questions or anything is needed. Next slide. Another big thing that was added was follow-up requirements, so that we're not just discharging these individuals out the door, but that there is continued follow-up once they leave. So follow-up for all facilities discharging an individual from an emergency mental health hold must include that it is regardless of discharge status, whether that's release, voluntary, or certified. that it's regardless of the type of facility and designation status that they were discharged from, and that that facility must attempt a follow-up contact with that individual or the individual's layperson or the individual's guardian within at least 48 hours post-discharge. They also may contract, whoops, can we go back to last slide? Thanks, Jenna. They also may contract with community-based behavioral health providers or the crisis hotline for follow-up requirements, though we want to note that 988 phone call alone is not sufficient enough to meet this requirement for follow-up, and that must receive authorization from the individual to share information to any contracted individuals. Now, this does not apply to individuals with Medicaid, as RAYs have the charge to follow up with these individuals, and that the facility to contact the RAY, the facility will contact the RAY regarding the member's mental health hold to ensure that follow-up is happening. Next slide. Some further updates that you'll see in the chapter is there's some more information around therapy or treatment using special procedures. So those procedures such as transcranial magnetic stimulation or TMS, ECT, and the use of feeding tubes for eating disorder treatment will require special procedures for consent, and that language is added into the chapter. We also have requirements for placement facilities. So agencies that use placement facilities will need to send placement facility contracts, or I'm sorry, sign placement facility contracts at least biennially, and those contracts will be submitted to the BHA at the same time as BHA license renewal. So that's at least twice a year for those placement facility contracts. Subsequent emergency mental health holds. Now, this is an area from stakeholder feedback that we're working on a little bit more. We're wanting to make sure that there's a definition for subsequent involuntary mental health holds that we're still workshopping a little bit to make sure that there's added clarity for this section. But subsequent involuntary mental health holds are allowable in both designated and non-designated emergency medical service facilities if an appropriate placement cannot be found. The facility must notify the court, so an attorney may be appointed. They also must notify the BHA and the individual's layperson if that individual chooses to have that person know what's going on. Next slide. There's an updated section to seclusion, restraint, and physical management. For those of you that joined us for the chapter 1 and 2 town hall, you'll see very similar language found in the chapter 15 seclusion, restraint, and physical management section. This includes further details on when these interventions can and cannot be used and appropriate policies and procedures that are needed by the agency to use these intervention techniques. There's also increased personnel training and demonstration of knowledge and application language that was taken from federal mandates around seclusion, restraint, and physical management. There's added standards of care at time of admission. This includes collaborating with the individual strategies that may minimize the potential for a behavioral health emergency event that requires these interventions. So we're wanting to make sure that that individual voice is heard. We want there to be an assessment for assault, trauma, and past seclusion, restraint, or physical management history. Also listing any other additional risk factors that could escalate a particular situation for an individual that where seclusion, restraint, or physical management may have to be used. The timelines for orders were changed to match federal regulations and standards to a maximum of 4 hours for an order. It was previously 24 hours, but we wanted to make sure that we were matching those federal regulations. Next slide. There's also increased regulations for protecting and monitoring individuals that include personnel may not be more than 10 feet away. Now, this is a proposal around that 10 feet. We did receive some stakeholder feedback as it was previously 6 feet, and that left staff or personnel within kicking distance of an individual. And so to make sure that everyone is staying safe, we're proposing a change to 10 feet distance, physical distance. There's also regulations around maintaining continuous line of sight and consistent efforts to interact throughout the episode. That personnel ensure for individuals in restraint that blood circulation and airways are not restricted or obstructed. And there's increased regulations for relief periods offered to the individual. We have language around debriefing with the individual post this event where they have to go through this intervention to ensure that there's an assessment for any further trauma that may be coming from this event and specific documentation requirements of intervention episodes. And lastly, for the seclusion, restraint, and physical management section, we have added additional regulations on seclusion, restraint, and physical management specifically for minors, and this was taken also from federal language. Next slide. A new section you'll see that also came out of that 22-1256 bill is about transportation holds, or M.5s. So these procedures for involuntary transportation holds can no longer be initiated by they can no longer be initiated by an intervening professional, only by an EMS provider or certified peace officer, as Jessica mentioned earlier when she was talking about the bill information. These individuals may not be transported for longer than 6 hours. And once the individual is presented to an outpatient mental health facility or a facility designated by the commissioner, an intervening professional will screen the individual immediately. Now, if an intervening professional is not immediately available, the individual must be screened as soon as possible, but no later than 8 hours after the individual's arrival at the facility to determine if the individual meets the criteria for an emergency mental health hold. Now, a quick note, and I know Jessica spoke on this earlier, but just another reminder, this does not apply to emergency departments. Those rights of those transportation hold rights that are new must be explained to the individual prior to transporting them involuntarily and provided to the individual in written form. Next slide. Those rights include, again, those timelines for transfer. So no longer than 14 hours for the detainment period, the not transferred for longer than 6 hours, and to receive screening immediately, but within no more than 8 hours. Now, this does not prohibit a facility from holding the individual as authorized by state and federal law, including the Federal Emergency Medical Treatment and Labor Act, or 42 U.S.C. SEC 1395 DD, or if the disorder impairs the individual's ability to make an informed decision to refuse care and the provider determines that further care is indicated. The individual has the right to request a phone call to an interested party prior to being transported. Now, if the certified peace officer or the EMS provider believe that access to a phone poses further harm or safety risks, the receiving facility will make the call on the individual's behalf immediately upon arrival at the receiving facility. Next slide. The individual has the right to wear their own clothes, keep and use their personal possessions that they had at the time of detainment. A facility can temporarily restrict an individual's access to personal clothing or personal possessions until a safety assessment is completed. Though the facility needs to have a discussion with the individual about why those items are being restricted. And then a licensed medical professional or a licensed mental health professional will conduct a safety assessment as soon as possible. Now, the licensed professional will document in the, my brain and my mouth are disconnecting here as we keep on going. The licensed professional will document in the individual's medical record the specific reasons why it is not safe for the individual to possess their clothing or any other personal possessions they may have. Next slide. We've got more rights for transportation. So the right to keep and use the individual's cell phone. Now, that language, keep and use, is straight out of statute. And so that is the language that was used in Chapter 15 for these particular rights surrounding cell phones. So unless access to the cell phone is determined that it will cause further destabilization or create a danger to the individual's self or others, as determined by the provider, the facility personnel, or security personnel involved in the individual's care. They have the right to access appropriate water and food as adequate for the individual's nutritional needs, and that they're met in a manner that is consistent with the recognized dietary practices of that individual. They have a right to be treated fairly with respect and recognition of the individual's dignity and individuality. And finally, a right to file a grievance with the BHA, the Department of Public Health and Environment, or CDPHE, or the Office of the Ombudsman for Behavioral Health Access to Care, established pursuant to 2783 of Colorado Revised Statute. Now, all of these rights may be denied only if access to the item, program, or service causes the individual to destabilize or creates further danger to themselves or others, as determined by that licensed mental health provider or professional person involved in the individual's care or transportation. Next slide. And to talk further about M forms, I'm going to pass it back over to Jessica.
Thanks, Mel. Oh, my camera's not on. Hold on. Okay, so as I mentioned previously, there are some updates to the M forms and to the patient rights to go along with not only these rule revisions, but also with that 1256 statute change. And so the M1 and the M5 forms, they're in their final edits this week, and then they will be heading over to our communications team to be put on our BHA website and will be ready for dissemination. Patient rights. Previously, there was only one form for patient rights, and now we have expanded that to 5 different versions. I know that sounds like a lot, but each one is very specific to where it is in the process of the mental hold, the 2765 processes. So we have transportation rights, and that will go along with the transportation hold. That particular rights form is for all ages. There is the emergency mental health hold rights. So when you have the M1, you also have a specific form for that. That one is also for all ages. When we start talking about certification of an individual, this is where it kind of splits off. So we have certification rights for adults and certification rights for minors. The minors' rights go into a very specific process around objection to hospitalization and what that looks like and how they would obtain their own attorney if they are above the age of 15, or a guardian ad litem if they are 14 and below. There's also voluntary hospitalization rights for minors, and all of these will be very clearly labeled based on the needs of your agency, of what particular individual you're working with, where you're at in that hold process or the certification process. And so those are just about finished right now. Those are out for translation. And so they will be translated into Spanish for certain. I am waiting on confirmation around some other languages that we have seen a need for. And then once those are finished with translation, all of those will be on the BHA website. I know I went through that very quickly. What questions are there around the M forms? Not seeing any, so maybe we can keep moving.
Oh, I think I did see one from Elizabeth, a clarifying question about the new M1 and M.5 is available on July 1st, 23. Does that also mean the new M forms can be used July 1st of 2023?
Yes, and please do use them. Any others? Voluntary rights forms for adults, those are going to be along with those certification rights. Those don't differentiate between voluntary and involuntary.
And then there was an earlier question that Tom wanted to address regarding the subsequent holds. Tom, would you like to take that one?
I will take that one. I think that Lori may have asked that. It's several pages back in the chat, so I'm doing from memory. I think the question was, how many subsequent holds are allowed? This goes back to the requirement for notification to the court and also to the BHA if there's going to be a subsequent 72-hour emergency hold placed. I believe it is the statutory intent for there only to be one additional subsequent hold allowed. I think the justification for that is that before that or during that subsequent hold, there needs to be notification to the court to have an attorney assigned, notification to BHA. The intent of the statute, I believe, is that we do not allow any additional beyond that second by requiring that notification, and that if the person continues to meet criteria, there should be a court process started to begin the short-term certification. And I think that that's the nexus with notification to the court to have an attorney assigned. Now, I realize there may be some ambiguity in the rule, and we can take a look at that requiring it. I would also, if people have a different interpretation of that, welcome your rationale and interpretation. Now, I realize we could probably spend several hours talking just about that. So I wonder if maybe the appropriate way to handle, if you disagree with that particular interpretation, is to email me directly. So I will put my name in the chat. And Lori, I see great on the one additional, maybe just the word one needs to be added. I think that would make a big difference in our rules. So thank you for that. I think that was it. Victoria, back to you. Any other questions?
Great, thanks. I saw Jessica addressed the transportation hold question. I'm wondering if we have an answer for that. Is there a hard stop date for the new M forms? Oh, and I see Jessica typed that while I was speaking. So the expectation would be to transition over to the new forms when they are available. I'm also going to quickly just jump back to again, we've got robust conversation happening in the chat and live. You all have certainly brought your A games with your questions today, and we appreciate that. We can provide clarity about, I think there's general confusion around terms biannual, biennial. Maybe we could even look at some clarifying language around every 2 years so that we don't have everyone Googling the difference between biannual and biennial.
That's my least favorite use of the term. I've always argued with the state that if I'm supposed to be paid bi-weekly, that I should get twice as many paychecks as I currently get. So I happen to disagree with the use of the term.
Very good. Yes, we can definitely make that a little bit clearer. And then there's also a question about, do we have an idea of where the M forms will be? Will there be a link? Any idea, or do we know what we're doing for distribution on that yet?
Just typing a response to that, and I'll put that in the chat so others also have a place to see it. I don't know the specific link just yet, but I would suggest signing up for that Quality and Standards newsletter, because that will be your fastest way to know when they are posted and what that link will be.
Great. Help us become the most popular newsletter at the BHA. Get all the latest from Quality and Standards. All right, I think we're mostly caught up here. And with that, we will continue on with our presentation.
Thank you so much, Victoria. Back to me again for just 2 more slides, and then I'll hand it over to Olivia to finish us out. We do have new additional procedures for minors. This also came out of that 22-1256 bill, as Jessica mentioned earlier. A minor who is 15 years of age or older may receive mental health services from a facility with or without consent from a parent or legal guardian. There are new rights specific to a minor, in addition to those rights listed in that 15.14.5 section of our chapter. They have the right to refuse to sign the admission consent form, the right to revoke consent at a later date. This will then trigger a review of the need for hospitalization if that revocation happens from the individual. They have the right to seek to be released from the facility, and they have the right to services that are suited to their specific individual needs, delivered in the least restrictive environment and delivered with an opportunity for family members to be involved when that's appropriate. Next slide. There is procedural information included in this section of Chapter 15 around the hospitalization procedures for minors. That includes that application process and the independent review process, that a minor may be admitted voluntarily or involuntarily, and for applications, an independent professional conducts an investigation unless that minor is 15 years or older and they are seeking voluntary admission. If that's the case, then that independent professional does not need to conduct an investigation. There's further language around that objection to hospitalization process for minors. That objection process for when a minor does not consent to or objects to continued hospitalization. That there's a need for continued hospitalization, and that must be reviewed within 10 days if that objection happens. And then what that process looks like with review in courts if continued objection happens after that independent professional review. Next slide. And with that, I will hand it over to Olivia for our last 6 slides of this Chapter 15 presentation.
All right, thanks, Mel. So we did go over some transportation rights, so just wanted to continue that, going over the individual rights for emergency mental health holds. Again, not all of these will be listed, or we would probably be here for 4 or 5 hours. So just going over to the big change ones. So an individual has the right to request a change to voluntary status, the right to have reasonable access to telephones or other communication devices, this does include cell phones, and to make and to receive calls or communications in private. The right to keep and use the individual's cell phone unless access to the cell phone causes the individual to destabilize or creates a danger to the individual's self or others, as determined by a provider, facility personnel member, or security personnel involved in the individual's care. The right to an individual's rights may be denied for good cause only by the professional person providing treatment. Denial of any right must in all cases be entered into the individual's treatment record. Information pertaining to a denial of rights contained in the individual's treatment record must be made available upon request to the individual or the individual's attorney. Individuals have the right to wear their own clothes, keep and use their own personal possessions, and keep and be allowed to spend a reasonable sum of their own money. A facility may temporarily restrict an individual's access to personal clothing or personal possessions until a safety assessment is completed. If the facility restricts an individual's access to personal clothing or personal possessions, the facility shall have a discussion with the individual about why the individual's personal clothing or personal possessions are being restricted. A licensed medical professional or a licensed mental health professional shall conduct a safety assessment as soon as possible. The licensed professional shall document in the individual's medical record the specific reasons why it is not safe for the individual to possess their own clothing or possessions. And the facility should periodically conduct additional safety assessments to determine whether the individual may possess their own clothing or possessions, with the goal of restoring the individual's rights established pursuant to this section. All right, so for our last few slides, I'm just going to go over the different designations within the 2765 designation. So starting us off with the emergency department facilities. This is our involuntary emergency services designation. This is a completely new designation that is optional for all emergency services or emergency departments. This will allow for the designated facilities to place individuals on a medical unit while on a hold or certification if needed. And if an emergency department does opt into this designation, they must be in compliance with parts 2.9, which is our dispute resolution, 2.17, critical incident reporting, and 2.25.5, right to appeal, as well as the data requirements from part 15.5.9, and they are exempt from all other data requirements within the chapter. Must be in compliance with part 15.7.3, the documentation and individual records, and part 15.14, our procedures for emergency mental health holds. For our involuntary short-term and long-term care and treatment designation, otherwise known as inpatient services, we were previously going to combine ATU and CSU, and if you were at our chapter 10 town hall, you will know that based on stakeholder feedback, we will just be keeping ATU and CSUs, and they will remain current state. These rules were adopted from CDPHE 6 CCR 1011-1, chapter 3. Within the inpatient services, there's outlined procedures for how facilities are to initiate and discontinue long-term and short-term certifications. There's new staffing requirements for all of these facilities. And when going to court for certifications, a recommendation of appropriate level of care, so inpatient or outpatient, must be specified. And they must have policies and procedures for therapeutic programming being offered and documented in the individual's treatment plan. Programming can include things like intensive case management, assertive community treatment, peer recovery support services, or other therapeutic activities. Then for our involuntary outpatient care and treatment designation, again, this is an entirely new section. So it has a new set of patient rights, which I will briefly cover in our last slide. And this designation specifies that facilities must possess a comprehensive safety net approval to provide involuntary outpatient care and treatment. An individual may receive involuntary treatment at an outpatient status if they are assessed as appropriate to place in an outpatient setting, if outpatient is better suited to the individual needs and welfare, and the designated facility holding the outpatient certification has documentation of a recent physical exam. There are also additional requirements for treatment planning, emphasizing finding and sustaining recovery and safety. So how will an outpatient certification be enforced if the individual refuses treatment and/or medication? The facility will be responsible for providing services and will proactively reach out to the individual or reach out to engage the individual. If the individual refuses treatment or court-ordered medications and is decompensating psychiatrically, the court may order a certified peace officer or secure transportation to transport the individual to an appropriate designated facility. The individual does not need to be imminently dangerous to self or others for the provider to request this transportation intervention with the individual. And then just briefly, the rights for this section. If you want to read all of them, you can go to chapter 15. But big ones are the right to request to change to voluntary status, the right to be treated fairly and with respect while receiving treatment appropriate to their needs and having a collaborative voice on what those needs are, and the right within 48 hours from request to be able to receive services of a patient representative, which includes a peer specialist. All right, and looks like we still have 25 minutes for questions. I have not been keeping up with the chat, so I'm going to pass it back to Victoria.
Thank you for that. We do have a few in the chat that we're working on, either responding in writing or live, and I do see a hand up. Mary, what do you have?
Yeah, can you clarify that new designation optional for emergency medical facilities? So it's common for people on mental health holds already to be on medical floors. What would change having that designation?
Tom, are you able to take this one?
Sure. So at this point, the Behavioral Health Administration does not have statutory authority to require that emergency departments seek and maintain designation. However, the BHA is happy to accept any application should an emergency department wish to seek voluntary 2765 designation. So the BHA's thought as to why that is an advantage is that we believe the recipients of service in an emergency department will benefit from the oversight and expertise of the BHA, but again, the BHA cannot require that of the emergency department.
And would that only be for emergency mental health holds, or would that also give a facility the ability to initiate a certification?
The facility can place an emergency hold through the authority of the specific staff within the emergency department, and they do and have been.
Right.
Does that answer your question, Mary?
No, would that designation also allow for an emergency medical facility to place a certification, or no?
The emergency department can start the process of a short-term certification. That's a court process. I don't think that it is typically their practice to do so, but I'm not sure the BHA is the right agency to answer that question. Again, we don't have any statutory authority over emergency departments.
Right. We've just been told historically from the BHA and OBH that you have to be a 2765 designated facility to initiate a certification. So I was just wondering if we got that designation, if something would change.
So the initiation of a shorter long-term certification is really a court process. Anyone can petition the court to attempt to place a person on a shorter long-term certification.
Okay. That's different guidance that we've been historically given from OBH or the BHA, but thank you.
All right, I did see some recommendations for some more specifics around some of the timelines here. So thank you for that feedback. I see a question from Audrey about the use of youth versus minor in the rules, particularly for the different rules for the 18 to 21-year-old range. I'm wondering, Mel, do you have any clarity that you can provide on that? I think specifically, I think it mostly comes into play in some of those seclusion and restraint pieces.
It does. Yes. Thank you. Great question. So the minor language was used to mirror off of the statutory language from 22-1256. The youth language is specifically used in that seclusion and restraint area, and that is to mirror the federal language from 42 CFR 483 subpart G. So that language is very specific. So I wanted to make sure that I mirrored that language from those federal requirements, but both minor and youth are defined.
Thank you. And while I've got you, Mel, I wonder if you might be the right person to talk a little bit more about, I know there was a 2765 designated provider meeting where we had a lengthy conversation about the rights to cell phones and kind of the intersecting concerns there around privacy and things like that. Are there any updates we can provide at this time about our thinking for the cell phone policies?
Great question. Right now, what we're looking at is including language around allowing the facility to create policies and procedures of how they will implement this rule within their facility appropriate to their population that they're serving. But while still maintaining that statutory call that specifically says individuals have the right to keep and use their cell phones while receiving treatment. We're not going to go into any prescriptive details around it, but right now we just have a policy and procedure section that we are creating actively right now before it goes over to the AG's office. I don't know if Jessica, if you wanted to add anything to that since we've chatted about this.
No, I think you covered it correctly.
Thank you for that. I do see a hand up from Megan.
Yes, no, and thank you so much. And I appreciate you touching on this further because this has been, I think, a top concern for our facilities, of course, wanting to provide as much both autonomy and rights to the patient, but also kind of how you do that in such a way that supports both their safety and privacy and staff's privacy and safety. I think, as you can imagine, some of the concerns they've heard are both around cell phones as a potential weapon against the patient themselves or against others, and so how that can be used. Also, the presence of the ability to do video calls or take photos of other patients in facilities. I think the request that we've gotten and appreciate the need to do flexible guidance and keep it from being overly prescriptive, but I think they are, and as much guidance from the attorneys within the BHA of just kind of guardrails and rules of the road of some type of flow chart of, okay, before you can do the evaluation, once the evaluation's been done, when the immediate threat happens, if the patient does this kind of, is there some way to do this in a supervised way? But again, just, I think the request we've been getting is as much guidance as physically possible to ensure that they're able to keep both their patients and their staff safe throughout kind of the provision of this requirement.
Absolutely. I truly appreciate that, Megan. And I want to emphasize again, in the statutory language and in the rules, it is in there that if the individual having access to their cell phone causes any further worries about destabilization or further harm to self or harm to others, behaviors are happening from having their possessions, including the cell phone, then that can be removed and then assessed further if it can be appropriately returned. So language is in both the statute and the rules so that some form of protection around that. But again, we're really wanting to lean on that policies and procedures for the facility. So, and again, I open it up to, I don't know if Tom, if you want to add anything.
Thanks for that, Mel. While I do recognize the request for additional specificity in the rules, in previous discussions about this, we have answered the question in terms of, we would like to see what the facility creates in terms of a policy for how they will handle these specific questions. In general, I like to proceed that way in terms of quality oversight. I think that gives more control to the facilities in question. For instance, while there is a right enumerated in the statute and in the regulations, the language is somewhat broad in terms of when the use of a cell phone is appropriate and when it becomes a danger to self or others. And I would think that clinicians within the facility and the facility itself would not want us to substitute our judgment through very specific rule about when that is or isn't appropriate. Now, I understand the ambiguity of leaving a more open rule and whether the regulated facility feels comfortable with that level of ambiguity. So I think that's the other side of the coin there, that sometimes there's more discretion from the facility standpoint and more discretion from the BHA standpoint in terms of enforcing a less specific rule. I don't think that's an answer. I think that's more of an overarching philosophy of enforcement. Megan, I would be curious about your specific thoughts to that response.
No, Tom, and that's incredibly helpful. And I think we're struggling with the same thing, as you can imagine, of recognizing, never wanting to be in instances where you're substituting provider judgment, but recognizing in cases of ambiguity that that there are risks there. And I think a good example we're seeing right now is one of our facilities actually just went through a seclusion and restraint corrective action plan, and kind of following that period, then have had 6 workers' comp claims, including serious injury related to kind of compliance with the plain reading of the regulation or plain reading of the law, and then kind of went on the back end where there's a consideration there, and obviously a risk to the patient safety and both the staff safety. And I think to the extent in cell phones, I see that as kind of having the same types of considerations. And so I think I worry about facilities who might interpret it. So they read the law or they read the regulations and say, okay, in all instances, we're going to do every single thing and prioritize X, Y, and Z. And so I think some type of matrix or something about how facilities and providers, or some type of work group or guidance of just how you make those determinations. So there is some type of statewide guidance or standard to make sure that facilities aren't stuck in the uncomfortable situation of having to make that call themselves, and then either come down in an instance where they could be surveyed and cited for either not complying with the regulation or the law, or on the opposite side, where you have a really unfortunate downstream effect of the patient is being put at risk or the staff is being put at risk. So again, I know these are all things that BHA has been grappling with as well, and just look forward to continuing to partner on this difficult conversation.
I think those are excellent suggestions, and I really do appreciate the dialogue. And I think this has been one of those hot button issues. Much like the 50% rule was in Rule 1.0, I think maybe this is the one for Rule 2.0. And I don't think we're going to come up with a definitive answer in this forum. I would just maybe leave this particular topic with one, thanks for the suggestions. We'll take in particular the suggestion of a flow chart or additional specificity in the rule back and discuss it internally. I would say this in terms of how I provide guidance within the Quality and Standards Division when any issue comes up with regard to regulatory interpretation and whether a citation should be issued. For me and the guidance that I provide each of the individual licensing managers, it is, what is the justification for the particular action that the facility in question takes? And if it's documented in the client chart, somewhere in the notes, that the facility did a certain thing or didn't do a certain thing, so act or omission, and what the justification is for that, my guidance is generally, then we don't issue a citation. And I would say that the same applies, again, very generally to cell phones. While there's a call for the person to be able to have and to use the cellular phone, if for whatever reason an individual clinician, the facility generally says, here's why the person doesn't have it. Let's see some documentation in the chart. They were trying to take pictures and they wouldn't follow staff direction to stop. They were attempting to take it apart to use it as a weapon against themselves or others, or a million other kinds of scenarios that I don't think we would be able to brainstorm here or back at the BHA, but that you as people that work in facilities would be and will come across. If we see those kinds of things in the chart, we're not going to issue a citation. We're going to say that that seems appropriate justification to protect the person, the staff, and other recipients of service. Again, we will continue to talk about it. I think there are probably lots of other questions in the chat that I didn't see as we were talking about cell phones. Maybe back to you, Victoria.
Yeah, so there's a question that's been coming up around age of consent for psychiatric medications. This has come up in a number of forums, and I think that the reason for that is, my understanding is the statutory language around this is not very clear and is fairly broad. And so this is one that we have on our list to get an opinion from our attorneys on about interpretation of that age of consent for psychiatric medication. So I think it keeps coming up because that is something that is unclear. And that is something that we need to get that legal opinion on. Anything you'd add to that, Tom?
I think that maybe when the rule changed, or rather the statute changed a couple of years ago to allow a minor who was 12 years of age or older without the consent of the parents to seek mental health treatment. It took us a little while to get that one worked out in rule and how we would handle that. And I think that we essentially have the same task in front of us. What are the regulatory guardrails that we put around consent to medication? So I think that's a specific question we should ask of our AGs. Then I would say we will provide that guidance in our final regulatory draft that we will take to the State Board of Human Services. Seeing if I get nods from the BHA team. That will reassure me.
Yes, that's one thing we've got flagged and would be prior to first reading. I see that Mel answered the question regarding additional procedures. Is this for physical management or just seclusion and restraint? Mel answered it's for seclusion, restraint, and or physical management that the facility may choose to utilize. And then I see another recommendation for a technical assistance document, a flowchart related to crisis evaluations versus screenings versus mental health code evaluations, what occurs where and by whom. So thank you for that recommendation, Angela. I think that's one of the big projects that we have once our rules are moving along and into legal review, is taking a look at the need for those technical assistance type documents, and that will be the work of our team to put together some handy dandy documents that should help provide some clarity for these big picture items.
I'd like to emphasize that, Victoria, if I could. I think that's exactly the right answer. The reason that we don't have them now, or part of the reason that the team's been very busy drafting rules and doing stakeholdering, maybe reason one. Reason two is we take these rules to our attorneys general and they say, well, that rule comports with the requirements of the statute, or it doesn't. Now, when we get that feedback, we will know that the rules as we have drafted them with your important input are constitutional. So that's when we can really start to provide those technical assistance documents that I think lots of people are asking for a variety of topics, something that the BHA and OBH has tried to do, but maybe hasn't done enough of. and that I would say in an overarching way is what we've heard loud and clear, what we asked for in terms of fiscal notes in response to the BHA bill and the authorizing statute for 2765, and that is more staff to do this work. So Jess and Courtney and a few other folks that are going to get hired to do 2765 specific training. That's the group of people that are going to create all of these technical assistance documents and do the training. So we know that the Colorado community needs that. That's important to us as well. So I look forward to getting more of that information out there.
Thank you for that, Tom. I saw a question from Charlie. Mel answered it before I could address it live. About the keeping and using cell phone rights, is that only applicable to the 2765 designated facilities or other types? That very specific right was a statutory right that was established for the 2765 designation. We do have our section on individual rights in behavioral health entities or BHEs. If you are interested in looking at those individual rights, those can be found in part 2.9. And then I saw the question from Angela about the bills that delayed implementation. Mel beat me again, 1256 and then the 1236. And I see we're coming up on just a few minutes left here. So might have time for one more question if someone has one. Again, one's not addressed live here. We do have the record of the chat and we will take those back. All right, I'm not seeing anything, so I think it may be time to wrap this up. Just want to thank you all so much for your time here today. And along this journey, this was our final rules town hall for this particular iteration of stakeholdering these proposed provider rules. And just want to thank you all for your partnership, for your expertise. And we are very excited to take a look at all of the feedback that is to come. We still have all of the feedback that's been provided so far, and take those into consideration as we make changes to our rules and move those forward. Just a brief update, or not update, but reminder, these rules, the feedback closes on midnight on June 23rd. The BHA staff will then take those that feedback into consideration, incorporate as appropriate into the rules before we send them off for our legal review. And then after the legal review, a new version will be made available, and that is what will be presented in our first reading at State Board in September. So again, thank you all, and hope you have a great rest of your day, unless anyone else had any last comments they wanted to make. Great. Well, with that, have a great rest of your day, and thank you so much.